questions from the audience now that you have the whole panel up here? I have one question, and it comes from, I think both Jamie and Bill talked about it, is, and we've seen it in orthopedics, some of the pilot projects, is you spend all this time and effort developing a bundling program, and then you get like 2 patients, right? So you spend all this time, and what did so even in the reference-based pricing system, there has to be a patient education process. You know, how do you push it out, and how do you get them engaged in that whole process to drive change? What are some of the practical things you could think about? Jamie, do you want to?
Well, I think you said 2 things there. One is that, just from your excellent remarks earlier, just how hard it is to improve the process of care. How much work it takes, how complicated this is. There's a lot of technical issues, data issues, a lot of cultural issues, and yet that's the only way it's going to improve is at that level. And so there needs to be, some people will do it just because they believe in it. That probably includes you. But others will do it. There needs to be some sort of a reward, and the usual reward is more business, more patients, more et cetera. And where a lot of this has fallen down is that there hasn't been a mechanism to get more patients to those places that are doing all the work. And so the work peters out after a while because there isn't that's what happened. We in the West Coast had a bundle payment also in ortho surgery, and because they didn't, this is my interpretation, we didn't have the benefit design co-aligned with that. The hospitals that put in the most work and the doctors, they didn't get much more business, and after a while, one after another, they dropped out because not they didn't believe in it, but just they had 17 other priorities, and so that's where that got me very much into thinking about either reference pricing or some other consumer incentive. And then the second part of your question was, well, if you want to do some sort of a consumer incentive, how do you do it? And I think one, it's got to be big enough that people can taste it. Giving small incentives, often people don't notice it against the background. On the other hand, you got to be concerned about people getting unexpected large financial bills. That's bad publicity, sticker shock, and so there's got to be you've got to have a communication campaign. There's got to be a good exceptions policy, and if people end up at the high-cost provider they didn't realize or whatever, you have to sort of manage your way through that. It's not worth going for a big effect in year 1 if that causes a backlash in year 2, and there is definitely a backlash brewing out there against consumer cost sharing, against high deductible health plans, against tiered formularies, against reference pricing. It's growing. It's out there, and if you don't think it can be powerful, it can be extremely powerful once that gets going. All you need to do is have sympathetic people that can talk about how they went into financial bankruptcy because of your benefit design, and you've got a problem. So I think being intelligent about this is important.
So did Calipers, after they developed the whole program, and somehow they had to roll it out to educate the patient as a consumer, which is not an easy task. So did they do anything special to roll out their programs to educate the patients that are part of their plan?
Well, they had a communication strategy, but what they really did, I think, in at least the orthosurgery one, was they tried to make it simple. People are busy. People don't have time for all this stuff, and so if you're trying to make it exotic, it's not going to happen. So they just listed, this is the list of the hospitals which are below the line, and these are the ones that are above the line. And that's what you need to know. Then they use the term value. These are the value ones, whatever that means. These are the ones, do that. And then with an exceptions policy and with a certain amount of, so I think that really the keeping it simple, and actually my big mantra is the single biggest problem in the US healthcare system is it's too complicated. It's too complicated, and we've got to make this simple, and all of us experts sitting around thinking of all kinds of cool programs that take a lot of time, whereas the total amount of time has not changed. The total amount of time is 24 hours per day. And frankly, speaking for myself, I don't want to spend a meaningful percentage of those 24 hours, making health care choices. I was like, no, give you a break. I've got more fun things to do.
Anyone else? Bill or Jessica?
Sorry.
I was just going to say, from an employer standpoint, getting to that point, you do invest a lot of time to create a direct contract. And as you may recall from my comments, I break it into two areas. Having been a CFO and trying to drive innovations inside of an organization, what we have seen is if you put one side is the structural side, that's going to be the modification of the plan, that's going to be the negotiation of the direct contract, it's going to be all of the elements that are paper. The other side of the equation is going to be the employee. And there are situations where it's been lopsided. We spent all this time negotiating a direct contract and it didn't work. So you've got to make sure that there's a good communication plan, as Jamie raised. You've got to have some type of incentive to drive people to this. There's organizations out there that provide enrollment services, so that can be part of the, and many of these enrollment firms are little or no cost to the employer, and they're spending 20 minutes with each employee each year or each period when the new benefits get rolled out. I mentioned the school district, that they're offering direct contracting and a bonus gets paid. It's not immediate, but it gets put into the employee's retirement plan. So there's a lot of flexibility out there, but you do need to use incentives, you need to use communication, and you need to build upon testimonials. We had a great experience at Tony's Surgical Center, and the other employees want to get to know that. So
there's a question from the floor. If you can introduce yourself again. And
yes, Diane. Am I on? Oh, yeah, she turned me on. Okay. Diane McClune with the Pittsburgh Business Group on Health. I have a question probably more for Jamie and Bill around bundle payments, okay? And that's to control cost. But do you have any results or any thoughts on the possibility that there's a decrease in number of therapies, early discharges, or supplies that might then result in adverse outcomes and or decreased quality? I mean, we know there's always a cause and effect. You do this, yes, there's going to be some kind of effect. So just wanted to know your thoughts on that.
So I think the question is, it gets back to the value equation, and are you tracking outcomes and quality at the same time as making changes in costs, and how do you do that?
Well, the one case I referenced is in a direct contracting situation. It enables an opportunity to build those quality outcomes and those employee experiences. I'm not saying that every direct contract goes that extra yard, but we are in our community recommending that happens, so that you can, with each patient that goes through the process, that you have some type of metrics and that there's communication between the provider and the employer. How did this one go? How do we make the next one better? And so forth. So I feel like the tool, the strategy direct contracting can come right to your point. And it just, again, it's having that conversation between the provider and the employer to make sure that both sides are getting what they want out of the relationship.
I would say, sorry. No, you go ahead. Well, the mother of all bundle payment is Medicare's DRG system. So the quality impacts of the DRG system have been studied extensively. There's a massive peer-reviewed literature on the topic, and you can prove that. I would say that just conceptually, any kind of bundle payment, as you move beyond DRGs, currently in episode is bundling the doctors as well as the facility, bundling the post-acute with the acute, et cetera. The question is, when you bundle things, that doesn't mean necessarily that you're reducing total costs or total payments. or not. You're just saying, I'm taking 5 different components and I'm adding them all up and I'm making one payment and giving it to those 5 providers and they have to figure it out themselves. Of course, the payer often says, oh, no, the whole point I'm going through this is to pay less. So I'm going to take 5 different components, I'm going to bundle them together, I'm going to cut off 20% or 5% or something, and then I'm going to give it to the providers and you guys figure it out. My view is that that's not the right way to go. That, in fact, bundle payment is a lot of work for the providers to adjust to it, to learn how to talk to one another, to do all this kind of work, that you really ought to be budget neutral in year 1 in any case. Whatever it was, if it was 5 different things or 2 different things, bundle them together, same amount of money, just give it to them in 1 check rather than in 2 checks or 5 checks. That then creates the incentive for them to start finding ways to share and coordinate and work together. And the efficiencies come, but they come over time. If you say you've got to give me savings in year 1, right when the hospitals and the doctors say, wait a minute, I just had to hire some staff to work on this. I had new information systems. I had to do all this stuff, and you want to pay me less. Their answer is, why would I want to do this? And then the short answer is, I don't want to do this. I won't do this, and that's why we don't have bundle payment.
So I could give you a different take on it from a payer-provider perspective. So when we decided to create a bundled payment for hip and knee, we put our provider and our payer team together, and we basically had all the data of what it's been costing, and we had all the infection rates, we had the readmission rates, we had a lot of the quality metrics, both that the provider had as well as the payer. And then we basically looked at the cost of what it was pretty much following Tony's methodology, right? Got all the orthopods in the room, basically let people argue about blood product and everything else, right? What devices, we were not going to determine that. The physicians were going to determine that. And the goal was to take out costs from the process, right? Mm-hmm. And simultaneously to improve the clinical outcomes. So part of and then we looked at it from a payer provider and said, if we can collectively make this less expensive. So they took a lot of cost out on the provider side. They were able to really make a difference. And we then had a product on the payer side to sell that basically helped us reduce our cost as an insurer. But the part of the incentive was to actually share back some of those savings with the provider, right? Because it shouldn't be that every time a provider gets more efficient, the only one who wins is the payer. And I would argue that otherwise it goes in the direction you're saying, which is everybody isn't aligned and they just keep fighting for the last penny. So the shared part, though, getting to the quality question, nobody got any extra money unless the global cost was a little lower, right? Because there was nothing to share otherwise. And whether there was a quality gate that met all the quality parameters first. So we first said, did you improve infection rate? Is quality measuring what the physician said is the best quality they wanted? And then let's talk about the dollars. So it's been an interesting, it's a couple-year journey right now. But we're seeing, certainly the cost of the episode is down, and the quality is higher than ever. So it's a good thing.
And I will say, just the piece of the cost information provided back to the doctors has generated the most conversation that I've seen among the group, the high-volume surgeons, than any other piece of information that we've gotten in the last 2 years.
Right, because providers really are fairly blind to what things cost in general. They know what they might do, but they don't see the whole. And the plan comes in with the whole. We don't have the granular. And the marriage of the granular information and the overarching information in a more of a population has been extremely helpful in design strategies.
Right. Question? Yes, Lauren.
Yes, I'm Dr. Lauren Roth from the Pitt Health Sciences, and that is medicine, nursing, pharmacy, and several others of our schools. And I also am from the UPMC Health Plan. So this question is to you, maybe primarily, Tony, but I'm very interested in what the panel would say about it too, because as you look around the room, there are no children, adolescents, 20-year-olds, 30-year-olds. those are the people we educate at Pitt as well as doing research. So my question to you, given what I think are the many fundamental, shall we say, truths, or certainly something interesting to talk about in what you do, is where would you put this type of thinking into the educational process of healthcare professionals? Because believe me, they do not get this as graduates. So it's all, why don't you change, instead of why didn't you practice what you learned?
Can I jump on that one? I sit on 2 college boards back in the Philadelphia area. One is University of the Sciences, 5 different colleges, much smaller than Pitt, but we are known for the oldest pharmacy college in the country, founded whatever, back in the mid-1800s. And I'm having those discussions all the time because there is a gap. And I have been approached to create a capstone course for the health sciences professionals that are being graduated to link the issues that we're talking about with what, from an academic standpoint, it's capstone for the undergraduate senior level, and then it's also open to the graduate students too, because every issue that we're facing from an employer standpoint, most of these students aren't prepared for. And so that's at least our little way of connecting, and if that is successful, then we would take that out to other colleges and universities across the country.
My answer to that too, we've had a lot of experience in this because we cover the spectrum from school up to senior physician. And first of all, the earlier the better in their training. And the second thing, again, is a practical tool, because we talk about this, is we found the most impactful tool for providers is the shadowing tool. And when you have a pharmacy student shadow a patient through a level 1 trauma experience, it just changes the way they view as being part of a team, because all our schools are siloed too. So it opens up eyes completely about how they're going to approach their training. So we actually have pilot programs with 2 nursing schools in Pittsburgh, RMU and Carlow. We've worked with the school of pharmacy. There's a group in England that developed from Liverpool that actually built the shadowing tool into their curriculum for medical students. So I would say earlier the better. And if you had a practical thing, it's to make them very early on shadow, become part of the patient and family unit, and follow them through their care experience. It could be any care experience, but it opens up their eyes, and it also shows that they're a team early in their training in ways that's very different than we've had in the past. Question? Another question in the audience? Can't see. There's one right in the middle.
Hi, I'm Frank Greco. I'm the Assistant Vice President of Human Resources at Chatham University. And I've been self-insured for about 4 years now. And last year, remarkably, I couldn't believe it, but going through my data, my specialty drugs soared. I was up over 34%. If I looked at my medical claims, were pretty flat, but my specialty drugs soared over 34%. I've been here, Diane touched upon, negotiating with the pharmaceutical companies, but very interested in some of the drugs out there for MS that's chronic, but they're very expensive for cancer. And interested to see, the difference between the countries is amazing, is that all the drugs obviously are much less in these other countries, and